bar site. You touch bar site, and then is there like a square, like a monitor screen you can touch too? So like you typically touch it first where you want to set, which is bar site, and then where you want to go, which would be on the screen. Okay. Try sending, and press one of the other ones. You have PC, right? Press PC. Okay, is the PC showing up on your screen? Okay. Is the PC turned on? Okay. You're not able to set any sources at all. Try doing this. Disconnect all. Now, can you try to send without being in BTC? At the bottom, there's like a non-BTC. Okay. Oh, really? Everyone. I'm working through what I think it should be, but okay. Try computer and just try to send the computer on it. Oh, it powers it off. No. You have a projector and then LCD. Okay. In the back, right? We were just here for like 40. So that's not your right? Okay. So it's not. You send separate stuff to those, so just to always all extra time. Okay. And you can't send it right now. You can't do it. But yeah, she's pretty. But you're not seeing it as anything. There's a lot of like roads were like totally closed from what I can see from over here. Yeah. Like kind of like so there's they're not. I mean, they're not. That's your. Not your brakes. There's like they shut down like being able to get to the top of it. Blank on that. But one did want to glass basically. Switcher does. Yeah. Your switcher is so that would be the first thing to do is do a power down from rack itself. Power down from the restaurant rack. Shut it down, either like just shut it down, don't shut it down, let it you can access the rack and actually power down. Okay. And with your rack, everything in okay. Yeah. So do that power cycle. That brings it up. You can find it. I mean, I think last week, Yeah. If not, call us and we'll check back in. Okay. So yeah, it might take a few minutes. Okay.
When we drop Roanoke, it goes back to BTC here, and I don't think it's like we just hit back and go to PC.
Yeah. You should be able to. Okay.
I'm going to, do you want to, in case he calls back, do you want to grab this? Or should
Okay, so here's what's going on in the class here.
Okay, yeah.
So,
Abingdon Abingdon, did that give you back what you had before? Huh? All right, you're good now. I just don't see Northern Virginia up there.
well, yeah, because it automatically split screened them, so if you look. Dr. D'Amico. See, they have a split screen in the back.
I did when I had running, so it's kind of already configured to do that. I can look at that.
Okay. Yeah. So.
All right.
It looks
Let me turn my mic up. I'll be right back, and then we'll get started. Hold that thought.
No, you're not.
Okay, guys. I believe we're ready to get started. I can see and hear from Abingdon, yes? Good morning. Welcome back. Northern Virginia, I see you over here, but I can't see you in the back. Can you see and hear me?
Can you hear us?
Yes. Good morning. How are you guys?
We're actually wondering how Jerry was doing.
I'll give you an update. 1 second. Let me make sure our connections are good here. Thank you for asking, though. All right. Roanoke, I understand you can hear me but not see me. We have confirmed we have the webcast. They're recording. Those will be available. We are still working. I have given Mr. Forder. Does anybody know who Mr. Forder is? Oh, guys, this is a huge announcement. I'm so excited. This is like an epiphany for me. We now have Mr. Michael Forder, who has joined the, he is one of our professional faculty. He is the director of e-learning officially and has a great deal of background in audio-visual, Echo 360. He set up all of our webcasts for us. As soon as we can come up with a more permanent plan, he's going to morph into what he was originally brought in to do, which is to enhance all of our e-learning in whatever format that occurs, but via our hybrid sessions, via online enhancements to our traditional schedule courses, working a lot with the new program, online CE, etc. So we have big plans for Mr. Michael Forder, and you'll see him kind of coming in and out here. So Mike Forder is on it. We also have the school's IT person working on it as well. At this moment, it appears that even though we use the connections over the break to Roanoke, for whatever reason, it's when we want to connect this morning, it seems a hardware issue. So we're rebooting. We'll get you back up and going. And I'm going to slow play just a little bit here at the beginning in hopes that we will get a full two-way connection. All right, the most important thing, Jerry. Jerry was moved to a rehabilitation center in the West End here in Richmond, probably about now going on, it was last Thursday. He is making progress, still dealing with a variety of issues, as you might imagine, but again, that's a huge milestone for him. We don't have a permanent fix on his most serious injury being the leg, but he does have one that's allowing him to at least get up into a chair and pivot and start to work on rehabbing the rest of him, which has held him back significantly. So he's still hurting a bit, still appreciates shout-outs from us, but we're making 2 steps forward, occasionally 1 step back. At the beginning, we were making 3 steps back, 2 steps forward, 3 steps back, 2 steps forward, so we're thrilled to say we're kind of going in the right direction at least. So that's the update at the moment. But his spirits are good. He misses us. He wants to be back. We don't have any idea even when that will be, but at any rate, there's some progress. All right. Everybody have a fun and relaxing break? Anybody completely overwhelmed already with what you have on your plate this semester? I just want to get a view of the hands. How many of you have already heard from your seniors, from me, from other people, second semester's worse than first? A couple in Abingdon. Northern Virginia, your seniors are getting at you. Roanoke, I can't see you guys. How about Richmond? How many here? Second? It just depends, folks. It depends. Everybody at this point, I didn't want to throw a ton of stuff on you over the break, but at this point, your goal in the next, how many days do you have till you go in the operating room? Everybody's counting. Everybody knows how many days you have, right? February 2nd? So you have the clock ticking. Your challenge at this moment is to just transition. Get into the spring semester. You get to start your didactic courses first, get your routines together, and then when you start in the operating room, at least for 6 weeks, you can start to establish a new routine. The challenge of the spring is endurance, physical tiredness, and trying to switch back and forth between didactic hat and clinical hat and didactic hat. And folks, they go together. They really do. They're meant to. It's meant to be that one enhances the other and vice versa. But it doesn't feel that way for a very long time when you're first getting up and going. I wanted to stress at the very, 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 very beginning, I know what else you have on your calendar this spring. I am going to be pushing you a little bit more in 603 for your benefit. I want you to really start to suck a little bit more out of these PMP classes than you're getting, have gotten in the past. Can you see us, Roanoke? Yeah! All right! Fantastic. All right, don't touch anything. Don't breathe, don't move. Don't breathe, don't move. The reboot.
I can't hear you.
Now you can't hear me? What? Thanks for saying it before the IT guys left out of the room.
We have now.
Can you hear me now? Can you hear me now?
Are we?
Okay, great. Do you want to hear me or see me?
They want to hear you.
They want to hear me. I want to see them, but better to hear than to see, yeah.
Well, they rebooted.
Okay, all right. They rebooted. We're going to motor on.
Because they rebooted their whole rack.
The whole thing.
Okay.
So it might take them to come in, or they might need to reboot it again. Sometimes
All right.
the devices don't like it.
The devices don't like it? I don't like them right now.
It's like a full body shock. It's not good.
It's defibrillation. We're stopping the heart, not restarting it. All right, there we go. All right, we're working. We're going. We're making it work. Roanoke, can you hear me? Let's let that sit for just a second.
They're going to have to do the echo.
All right, well, you will have to.
All right.
Here's this. You have the phone to tell them. All right, can you? Yes.
All right, we'll work on
Yeah, you got it. All right. So excited. And then beat me down. All right. They're going to text you. I'm going to type it in here. All right. They're going to text you guys and let you know what's going on in Roanoke. All right, I know what else is on your schedule. I know what else you're doing in other classes. I am going to push a little bit more. I'm not going to spend a lot of time marching through the course syllabus today. I want to jump right in, and that's kind of the theme of this spring semester. We're going to just sort of jump in. Though, you got a little bit of a break today, yes, because it's Tuesday, not Monday. A little earlier start, but then no long day. So hopefully we'll ease you in a little bit on there. Everybody was able to access the course on Blackboard? Yes? There's a syllabus there. I am going to march through the various assignments this semester. A couple of really key points. There are 2 labs. Please look at the dates for those. The dates for the Advanced Airway Lab are announced, and I'll be getting immediately with my distance site students to start making arrangements, roommate requests, and such. So I wouldn't say it's all a party, but you will have an opportunity for face-to-face bonding with all of our students for all sites, and not encouraging any sort of extracurricular activities of any sort, but just saying they're coming here so we can start making some plans for that. And we have a busy couple of days when you're here. It's like a full 8-hour day on the Thursday in April and a half day on Friday. We are going to do the pig trachea dissections that day, so it's kind of a nasty day. It's also a nasty morning to come into if you have a hangover, just saying. That's the April lab. I am working out the details to see who my travel partners will be. I will be traveling to all of our distance sites. I want to do the labs here in Richmond, and I want to do the labs at each of the distance sites. So I'm going to work out the schedule so that I can make all 5 of those things happen, 2 here, 3 there. So the dates for that, which if you've talked to your seniors, you will know that they have been shifted back in the schedule. I believe I've mentioned this before. That is because of having been canceled twice with each trip that I tried to make in the last 2 years. Each year canceled twice. We'd reschedule, bad weather. We'd reschedule, bad. So I've shifted that back in the semester just a little bit. It was a pretty non-substantial switch in terms of content. So the 2 labs and no cumulative final. The rest of the information is in the syllabus, and I will kind of march through that in extracurricular time because some of you don't want to do that in times. I can read the syllabus and others have a little more questions about the assignments. I did post last evening late, probably after 9 o'clock, the additional details about the care plan assignment. It is really not a massive issue on your calendar in the spring, guys, meant to be something that starts to really get you into the routine of making care plans, which are 100% for your benefit, not ours, not those of the preceptors. These are for you guys. It's not a nursing care plan a la what you may have done in the past. This is something that truly will help you. And guys, if I didn't stress it enough in the fall, I've already started stressing this to our new super excited entry to practice DNAP students. You should have seen the enthusiasm. If you need a little bit of a boost in the arm, talk to someone in the ETP DNAP cohort. They're like, yeah, ready to go. Lay it on me. I'm like, whoa. So if you need enthusiasm, call up those folks. We did not assign you to them as seniors, but I'm happy to find you one if you need some enthusiasm at any point. They've got every bit of enthusiasm an sRNA could possibly possess. So at any rate, we've talked with them about starting a repository. This is a really great time to do that, guys. We're starting to hear NCE results, horror stories from and about that, and I can't possibly stress enough the importance of working on that file cabinet, virtual or physical. Your care plans are meant to start filling that. Look at the NCE outline. Those are essentially the kinds of cases you're going to be assigned to do. They're in that outline, and when you do a case, which may be your one or just a handful of times you get exposed to that, you should have then a little folder in your file box that will help you, okay, here's the stuff that I need to know about TERP for the NCE. So if you don't already have that set up, now's a really good time to do that. We're really getting into care planning and starting to fill that file box this spring. Okay. Are we ready to get going? Inclement weather. Please be sure to review the inclement weather policy. We do our very, 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 very best to hold class when we can. If it is held in Richmond, it will be webcast, though we know that sometimes the other sites are not able to get in to their sites. We'll work with you guys on that. It's just a case-by-case situation. Everyone knows you're adults. This is, in the grand scheme of things, you are non-essential personnel. There is absolutely no reason in any circumstance when you think I will end up on the side of the road in a ditch, face up. Please don't come. So we understand that you guys are adults. You will make a decision based on the conditions at your place, but we're going to do our best to let the impact of any inclement weather, which has already been huge. We had to cancel our entire first 2 to 3 days of on-campus session for the DNAP. This is the postmasters section, thankfully not our ETP. So we're already testy about the weather on this end of things, guys. It's just already been a major impact for us. My kids were out of school for 3 or 4 days. It's like I'm already done with winter and we're January 17th. So we'll make that a case-by-case situation. If you have any questions, concerns, what have you, please let me know. And again, we'll kind of let this situation unfold as it does. Hopefully, anybody seen any in the forecast in the near future for any of our sites? Thankfully, no. It looks like we're kind of in the clear 40s to 60s. So, all right, let's jump in. I want to, the first hour that we have together today, I'm going to try to get my view of Northern Virginia back over here. Sorry in advance if that messes anything up in the other. I want to see Northern Virginia folks. All right, gung-ho, such enthusiasm. All right, the first hour of content here we're going to step into. This is a lecture that I pulled together is really to start to try to get you guys to think towards pulling all of the information that you've gotten so far in class together. So we're going to lay the foundation. I'm really going to just point out a lot of things that I want you to review going into the section of the course that is devoted to pulmonary diseases. In the second hour of today, we're going to march into COPD. I expect in the PMP courses that you have had some exposure to these conditions. We cannot spend a ton of time on pathophysiology. I will point you out to resources and references if you feel you need a refresher on that. But we will largely stick to, and you'll notice in the objectives for a lot of the lectures, what is the anesthetic implication of this condition, what kind of medications will these patients be on, what impact does that have on our anesthetic plan of care, what do we need to do different because this person has this history, etc. So very much focused on principles and practice, how do we manage patients who present to the operating room with these conditions, and less so on pathophysiology. I'm fairly rigid on that, guys, because I just don't have enough time. I haven't changed the semester. I never have enough time. I craft out as much as I can to be with you guys. But in terms of the time that we have together to really talk shop about these things, I will never have enough podium time, even if I took everything in the entire semester, and I have conceded some of my time this semester to others, in some cases a lot of others. So we're going to have to, again, point you to the right resources, and I'm here for you. If you have any questions about where do I find more information about this, I'm weak on this, I just don't get the bridge between that and this care plan, why that's so important, that's what we can do in this outside of class time, one-on-one, video conference, small group, whatever you need. Just let me know what you don't get, but we will not spend a lot of time. This hour was new a couple of years ago, and it was because I was seeing there was this sort of difficulty in jumping from pharmacology. We've learned about all these anesthetic drugs, but then we go into the operating room, and it's really difficult to kind of put all of that together and recognize the impact on, in this case, the pulmonary system. We have all these individual pieces and parts and things we do. We've talked about positioning, pharmacology, induction. You're going to be starting to do some of your own inductions. And in order to manage your patients in the perioperative period in terms of their ventilatory strategies, to their pulmonary system, to promote patient safety in that entire area, you really have to be able to pull all of that together. So I'm trying to pull together some information and kind of get your mind thinking in the right direction. We're not going to go into a lot of detail about a lot of the stuff in this first 25 minutes. My challenge in the spring is I'm no longer your last class of the day. I will end by 10 minutes till the next hour. I will get the hook out and make our lectures come off the podium 10 minutes before the next hour. So it's what the time we have. So I just wanted to point out to you, a couple of these things are things that you're going to revisit with multiple lectures. So I just want to put it out there. If you don't already have a good feeling about lung volumes and capacities, you better review it. It is absolutely NCE material, and it will underpin multiple lectures this semester. It comes up often in the clinical arena, and other lecturers will mention, I've asked them not to spend a ton of time on it because we've put it out there. This is something that you have to know, and I'm going to tell you what you need to know about them. Again, we're going to talk about the effects of anesthesia, sort of gestalt, this whole bigger picture of the effects of general anesthesia when you put it all together on the pulmonary system, it's a huge impact in healthy patients. It is an overwhelming impact in patients who have pulmonary disease at baseline. We'll talk a little bit about the ventilation perfusion relationships in the lung. If you don't have an understanding of that at baseline, when we start to get into things like one lung ventilation with lateral position, it becomes overwhelming. So it's a good opportunity to think about these things in the supine patient, healthy lungs, not having thoracic surgery. Roanoke, can you hear me now? Really?
Yeah. We can.
All right.
Thank you.
Got it. We're really just marching into content. First hour of content. Quit giving me that phone back. Every time I take it.
I don't want to see it again.
All right, but you may not have my phone again, sir. I'm locking it. We're done. I was just telling the other folks in class, you'll hear this on the webcast, that we're going to just introduce some things that this is essentially pointing you the direction where you need to review. I've just pulled, I saw that we now have a copy of Nunn's respiratory physiology text online. It's the 2017 edition. I'll refer you to that. If you need a basic review of pulmonary physiology, much of it very clinical based, that's a really great source, and I'll post some of those. I have a supplemental info tab on Blackboard. I'm going to have some fun with that tab this semester. Some really great stuff. I just found a few nice, really cool articles. So I'm going to point you in the direction if you need some sort of refresher on that. All right. So again, we're just going to try to pull some of these things together and point you in the right direction. Some of the reasons that we're so concerned about this, why do we care about the overall impact of all of the things that we do on the pulmonary system? Most patients who are healthy, most patients with pulmonary disease come through surgery just fine, right? Maybe, for the length of time that we see them. But this is one of those situations, like so much of what we do, guys. If they look like they're doing fine in the PACU, their SATs are good in the PACU, we assume that they're totally fine. They're extubated. I got them to the PACU. Drop the microphone. I'm good. And that is not the case. There are many, many, many things that we can do that will prevent those delayed complications and issues that these folks have that we don't see. So the biggest concerns, of course, are impaired oxygenation. The other is postoperative pulmonary complications. So these are really huge concerns. Impaired ventilation certainly is an issue as well. I kind of skipped over that. But let's look at this point here, guys. Most anesthetized patients have impaired oxygenation at some point in the perioperative course. And if you look at the statistics on this, it's frightening. Patients have desaturations to serious low levels of oxygen saturation frequently during the perioperative period. We're also worried about postoperative issues. Some of the high-risk categories are listed here. And then, of course, we're very concerned about postoperative pulmonary complications, those delayed complications that we don't see. Just to give you, this is a really good review article. This is not a required reading. It's not testable material, but it's a really, really great refresher on the impact of postoperative pulmonary complications. And I do want you to know this. Postoperative pulmonary complications occur twice as often as postoperative cardiac complications, particularly major ones. So we see this a lot, and we're talking about things that you may not automatically think of as a postoperative pulmonary complication, atelectasis, any episodes of bronchospasm, whether the person had a history of it or not, bronchitis post-op, tracheobronchitis, postoperative pneumonia, and then, of course, the more serious things. We certainly don't want to be one of many hits that then end up putting the person in a situation where they end up in the unit with ARDS, long-term mechanical ventilation, etc., and certainly postoperative respiratory failure requiring long-term ventilation. So this is a serious situation. It's something that, again, because we don't see it, we think that postoperative pulmonary complications are not common. They only occur in patients who are at high risk. It's not true. They certainly do happen more often. What are a couple of the biggest risk factors for this? Underlying disease, advanced age, very obese patients. What else? What are some of the surgical factors? Hearing positioning, yes. How about in Roanoke? I'm so anxious to hear from you guys. What are other big risk factors, surgical risk factors?
Blood loss?
Certainly, big blood loss. You're really speaking, I'm gonna give you sort of that's a hint at major surgery. What are major surgeries? cardiac, thoracic, big vascular, big belly surgeries. Big belly surgeries. Those are the major surgeries. So whether the person came into this relatively healthy and had to have one of these major surgeries because of a new pulmonary nodule or something, they may have been, maybe it's a person who is not a former smoker and such who ended up with lung cancer for that. Maybe it was just one of these, we don't know why they got it. For whatever reason, somebody who has major cardiovascular surgery, major thoracic surgery, and big peripheral vascular diseases, big belly surgeries. Those are some of the highest risk factors in terms of surgical risk. And then the person who at baseline is at risk of complications no matter what they do. That's usually their underlying disease. Your ASA3 patients, ASA4 patients who have multiple comorbidities and who walk around on a daily basis with a risk of going into congestive heart failure and so forth. So they happen certainly more often in those patients, but particularly the lesser complications, things like significant atelectasis that results in poor oxygenation postoperatively, bronchitis, pneumonia, those things can happen even in patients who are neither of the aforementioned categories. So these things are not rare. So we're going to try to pull together the effects of general anesthesia, if you will. We will not largely get into the specific effects. I mean, certainly if you have a spinal anesthetic that will compromise your respiratory function, that will have an impact here. But I'm really going to stick mostly to the general anesthesia. You guys are not going to get, to a large extent, into that right away in the clinical arena. You may, but for the most part, we're trying to get you guys up and going on patients who have general anesthesia, and in most cases, patients who have an endotracheal tube. Though the percentage of patients today that receive an endotracheal tube as the airway management plan for their general anesthetic it's less and less and less all the time, and it depends on the setting. Some of the things that I'll talk about will apply to whether or not they had an endotracheal tube or an LMA. Ideally, the impact is less if they have an LMA, right? They're spontaneously breathing. Maybe not so much. A poorly managed LMA case can be a huge risk for postoperative pulmonary complications. So we're going to really kind of focus on what happens in each of these phases that will contribute to pulmonary dysfunction, and I hope it's, kind of bringing together some things maybe that you haven't thought about. Are there preoperative issues? So before we've done anything, all we've done at this point, we've met the person. We scheduled them for surgery. What does that do? Any impact by scheduling a person for a surgery, minor or major? Doesn't matter if it's a minor surgery, right? They're panicked. They've now been not sleeping, not eating the same, not drinking the day before surgery up until right. So we've already dehydrated them. We've upset their entire routines for the week. I mean, think about those things, guys. Just by scheduling them, we haven't even come into the game yet. We haven't talked to them about anesthesia. People come to the day of surgery, they're panicked, and that has an impact. I mean, we know that in terms of a holistic view of the patient, we've already done a lot to them just by getting them there that day. And then what else do we do? Your surgery's at 9. We need you here at 4 o'clock in the morning. So we sleep deprive them, we dehydrate them, we get them anxious, they're tachypnic, their blood pressure's up, everything's off. And then we also do what with their medications? We totally derange their schedule, which they may have had things kind of all worked out. So guys, we haven't even done anything yet, and some of the things that have occurred outside of our control have already put them into a situation where their risk is elevated, and we've not done anything, and this can be a minor surgery. So just some of the things that we might think about. Again, what are the effects of dehydration? I've listed some of them out here. You guys know those things. We've dehydrated these patients, and that certainly has an impact on their pulmonary system. And then we also start to then add, what do we do when they come into the operating room? Hopefully we'll undo a little bit of the dehydration by starting to get them hydrated, but we've got them more anxious because we're poking needles in them now. Then we may start to give other medications. We may give specific drying agents. We will start to give them anti-anxiety medications. We're trying to help, but those anti-anxiety medications have an impact on the pulmonary system as well. So again, just trying to get you guys to think about that. Here's something that's key that you may not have thought of in the past, and this becomes fundamental. I cannot tell you how often people forget about this. What does the body normally do in response to an increase in the PaCO2? We have what in our body? We have all these receptors that sense the acid-base status in our blood, yes, and in response to an elevated CO2, what does our body normally do? Well, increased respirations. We're trying to maintain zero balance here. We want to maintain homeostasis. So remember that, and remember that almost all of the drugs that we give in the perioperative period have an impact on our body's ability to do. It affects the body's ability to do that. So it screws up its ability to maintain homeostasis. We forget about that. So we think it's a young, healthy person who has no pulmonary history. We've already deranged their internal sensing and response system. So think about that, and think about that when you're looking at drugs that we give. What impact will those things have on the body's ability to respond to elevations in PaCO2? So here's just sort of a general alveolar ventilation. We normally, in response to an increase in the PaCO2, here's the awake state, no drugs. Look at how much we go up with just a little bit of a change in PaCO2. All right, so let's say we give sedative doses of opioids. Now it takes a bigger change in PaCO2 to see the same change here. That's what we're talking about. So what does it do to that CO2 response curve? You'll hear us talk about that a lot. Sedative doses, very small doses of propofol, benzodiazepines, narcotics. What do those things do? Right and downshift the response, CO2 response curve. And here's the numbers on that. Healthy awake patients' minute ventilation increases 2 liters per minute for every millimeter in end-tidal CO2. Significant. All right, there we go. So let's kind of just, again, march through. Now we've talked about the preoperative phase. That really does certainly vary. Depends on how much sedative agents, how much drug of the various types that we've given, even if we're giving nothing. Certainly there's already some pulmonary impact there. Now we're going to go into the perioperative period, and we're going to do a lot of other things in a very short period of time. So we're going to just kind of march through the phases of anesthesia, just kind of thinking through what the impact of some of these things might be. We get into the operating room. Let's say we've given nothing else in addition to what they had out in the preoperative area. One of the biggest impacts the patients will have from, in terms of the pulmonary system is that we take them from an upright position and we lay them completely flat. And how many of you have laid completely flat lately? On our regular beds, we normally have pillows, right? We just naturally put ourselves up. Lay on an operating room table sometime. And half the time, there's still a little bit of T-birth from the last time. And then you put the safety strap on your belly, just laying a person supine in the operating room. Boom, another big hit. And an awake, healthy person, not really such a big deal. I want you to remember supine, and we're going to talk in a little bit about closing capacity. Closing capacity approximately goes, you will have an impact from, you may be at a lung volume that equals closing capacity in the supine position in a person as young as 45 years old. So you may simply by virtue of going to a supine position, even in a person as young as 45 years old, healthy, no pulmonary disease, you may put their lung volumes to a point that they are already about at their closing capacity. The lung volume at which they will start to see small airway closure as young as 45 years old. That's pretty scary to me. What's the next thing we do? No other drugs IV yet. We're going to put them on 100% FiO2. Certainly that has an impact on the pulmonary system. We have good reasons that we do that, but it has an impact on the pulmonary system in terms of promoting atelectasis. Absolutely does. And then we're going to start to work in not little whiffs of medication, not a milligram or two of Versed and 25 mics or 50 mics of fentanyl. Now we're going to start our induction, which often takes place over multiple, minutes. We will, in many cases, give these drugs. We want them on board 5 to 10 minutes prior to us actually giving the induction dose of propofol. Is everybody comfortable with drug dosing and induction dosing for drugs right now? There's a great thing to review before you go into the operating room. Some of you will go into situations on February 2nd where they will already start to say, oh, you're going to go ahead and push your drugs. Most of you will go into a situation where they recognize, okay, your scrubs are on backwards and you showed up in the wrong room, probably shouldn't be pushing your own drugs. But ultimately, soon, some of you in private practice especially will be pushing your own drugs very, very early. You need to know in what order you push those. We're not going to get into that to a large extent here, but it's a good time to start having that conversation. And it's a great conversation to have with your seniors as you're talking to them. How many have already contacted the person they're going to be assigned to the same site with when they show up the first day in clinical. Closer to the time, hopefully all of you will have done that. Contact a senior who's already there. Talk with them. Places have their own right way. I have a way that in the order in which I push drugs, I have a really solid reason why that's the right way. The D'Amico way is it. No, it isn't. There's a lot of different ways to do this. There's so many other factors that go into that. So start talking to them about what is the institutional culture and how do they do things in that institution. In some places, they are going to smack your hand, not literally, hopefully. They're going to be very, very harsh on you if you've pushed this drug before this one or this one too far out. And others, I cannot believe that somebody with 2 weeks of clinical under their belt doesn't know that you should push this drug when I think you should push it. So it's a good conversation to have. But I digress. We're going to give big doses in many cases of narcotics. We're going to give additional sedative medications and lidocaine before we've induced the patient, after we just put them in supine position. So we have already to this point seen significant impact on the pulmonary system. To what degree? There's a really great article. I just can't say enough about it. I've just fallen in love with this article over the last couple of years on pulmonary atelectasis. It's posted to Blackboard. It is a required reading. How many are aware that you're having quizzes this semester? First one we'll post today. These are prospective quizzes purely based on readings. I have put together this article, Pulmonary Atelectasis, a Pathogenic Perioperative Entity. This one gets into the weeds a little bit, but there are some general concepts that are in here that I think are absolutely fundamental and things that you really, really do need to know. So what I put together for this is really, if you will, and I'll post this today when I put up the quiz, it's a guide to like what are some of the key points that you really need to get out of this article, and they're not in the weeds. They're really at a level of very clinically relevant information that you guys need to know. But I can't stress enough, this is a really important article. And some of the things that it points out are on this slide here, and that is to what extent is FRC decreased. And this isn't a person, remember, we're not talking about a patient with pulmonary disease. We're talking about a healthy, relatively young person. FRC decreases, and I'm just talking about going from the supine position, from going here to totally flat on the floor. Would you and I notice that if we lose half to 1 liter of our FRC? What is normal FRC? You'll know it in a couple weeks. What is normal FRC? That's a significant decrease in your FRC, functional residual capacity. It's one of the lung capacities we'll talk about. That is significant, and it is significantly impacted just by assuming the supine position. Already a setup for atelectasis in a healthy person who's not ventilated at this point. Closing capacity is independent of position. There's some controversy, if you will, in some sources on this. I've looked this up numerous times. Closing capacity independent of position. You need to know what closing capacity is, how it changes throughout the lifespan. I pointed you to some references on that. And what does that mean if FRC decreases but closing capacity doesn't? FRC is normally, I have a slide here, higher. We're looking at lung volumes. This is 0. We're going to get into these a little bit. 0 lung volume. This is functional residual capacity. This is a great graphic to know, possibly be able to draw functional residual capacity here, closing capacity here. So your functional residual capacity is typically higher than the lung volume at which you see small airway closure. So in normal tidal volume breathing, in a normal healthy upright person, we don't see airway closure at the end of our tidal volume, right? That makes sense. But if your closing capacity stays the same and your FRC drops down, tidal volume breathing occurs here, yes, then we may see small airway closure at normal tidal breathing. So that's the impact of that. We may see small airway closure. We may start to see atelectasis. How many want to go back to bed? Okay. All right. How are we not getting this to go back here? We're stuck. Okay. Again, can't stress enough, this is a really great graphic to know. Everybody understands the concept that a capacity is the sum of other lung volumes. A capacity is always the sum of something else. You need to know what it's the sum of. What values constitute the FRC? It's on this graphic, so there's a lot of little tools that you can use to do this. I don't personally endorse mnemonics. I've had nothing occur in the last month as I've talked to my folks who've taken the NCE that changes my thinking on the idea that mnemonics are a really great way to go. I recognize they help some of you guys. So I don't promote them, I don't come up with them, I don't use them. I just try to dig it in, pull it apart, put it back together. But I know that some of your seniors and others do use them. I'm not saying they're all bad. If they work for you, use them, but I just don't. I want you to know this. If it takes a mnemonic to help you do that, do it. But I've also, again, seen some situations where over-dependence on mnemonics makes you not really dig in and pull it apart, get to know it, love it, own it, put it back together in your long-term memory. So if you're using mnemonics, fine, but don't have them as your only strategy to learn that material. I'm digressing so much here. You get that. All right, so what are the lung volumes that comprise the FRC? Residual volume, expiratory reserve volume. You need to know these things because we're going to talk about pulmonary diseases, and we'll talk about the impacts. What are the characteristic findings of a particular pulmonary disease? A lot of it comes back to what is the impact of that disease on these lung volumes. We do use pulmonary function testing as a mechanism to diagnose pulmonary disease. So you need to know what these things are. Slightly different than PFT and how we measure those things. But it's helpful to understand this in order to understand what are the characteristic changes of patients who have a particular disorder. Okay. I wanted to point out here, this is table 26.4 from Nagelhout. This is the reference values that I will use. And again, it shows you all of the various volumes, all of the lung capacities. This plus this plus this plus this equals this. The graphic helps you do all of that on your own. So drawing it, much like drawing the brachial plexus, there's a few things in the program. I think there's no better way to learn it than learn to draw it and learn to draw it again and draw it 1,000 times. And when you've done that, then you can put that out on your paper. You understand the concepts of it, and then you can derive this information from that. The numbers, you really do largely have to just know. They will vary a little bit from source to source, but thankfully not in our anesthesia texts. So these are the numbers that we will use for the reference values as a normal FRC. Normal FRC, 2.3 liters or 2,300 mLs. And these are referenced essentially for a 70-kilogram adult. Recognizing how many patients, what percentage of our patients are 70 kilograms? Like 0. Okay, I'm lucky in this case because this matches up nicely. I believe that I took this chart from Morgan and McHale. But if you get to the time of a test and you say, oh, but I remembered a different reference value for this, I'm just going to tell you again, sometimes we just have to say, for the purposes of this class, these are normal values. The others are ish, 2,300-ish. These match up nicely with Nagelhout. It's just the information presented in a different way. I've already drawn on this one. Again, this one adds in here the closing capacity as well. And the biggest thing about that is just recognizing that some of the things that we do, namely positioning and such, will have an impact on closing capacity, and that will make it such that we have small airway closure as a result of those things. And this is from the Morgan and McHale's. All right, what's going on here? Ah, phew. Get rid of these. Just trying to advance the slide. Come on. Okay. This is what I was talking about before. You'll find this in a number of respiratory physiology texts. And this is age on the bottom, lung volumes. So you can see functional residual capacity in the supine patient. They're listing functional residual capacity in the upright patient up on the top. So they've got upright patient around 3 liters. That's where you see some variation. You don't need to remember specific numbers from this graphic, just recognizing that there is a significant change in the FRC just from going from the, what is the relationship between FRC and age? You will see some variation in this because there is some change in one of the components that makes up the FRC. However, largely, functionally, what is the relationship between FRC and age? So this is not showing that. If you look along this, a 30-year-old upright FRC the same, 40-year-old FRC the same. So for the most part, not hard and fast, but in general, FRC does not largely change with age. The components that comprise the overall FRC do, and certainly in some sources you'll see that there is a modest increase in FRC. What was your question?
Is it the reserve volume goes up in the next or the residual volume goes up?
Correct. Exactly. Exactly. The residual volume is the one that does, in some, will change as we age. So, what is the impact of that? So I've just told you that closing capacity is independent of position, but not so with age. This graphic will show you that. At 30 years old, your closing capacity is lower, so there's more room between your FRC and your closing capacity when you're younger. As you age, the closing capacity increases such that it will meet your FRC. This is a really important graph to kind of wrap your mind around, walk through it. So closing capacity increases slightly with age. What is this break point here? Where's the point at which FRC and closing capacity meet? Around 45 years old. That's what I just described to you earlier. So in the supine position, the impact of that position, which affects your closing capacity, it increases the lung volume. You will see that some people who are 45 years old, just by going to the supine position, will have small airway closure at that point. Make sense? In the upright position, the cross point, this reference shows it a little bit shorter. It's as we age, but there is a break point at which your closing capacity is increased such that you may see in the upright position small airway closure. Your closing capacity in FRC will meet. And many sources will put this around 65 to 75 in that range. Just depends on the study that you're looking at. So even in the upright position. What does that mean? Standing up, a 75-year-old healthy person with no lung disease may be already at that break point when they walk in the door, and then we put them in the supine position, and we see this significant drop in their FRC. There's a lot more airway closure going on in the elderly person than there is in the younger person. So that's why advanced age has really marched out to be a significant risk factor for postoperative pulmonary complications, because atelectasis is an entity of itself, and it's a risk factor for volume trauma, repetitive biotrauma. You have small airway closure, that means you got to pop them open every time. And if your ventilatory strategies are not sufficient to keep those small airways open during anesthesia, you have significant atelectasis, you will have significant volume trauma, all these things. You end up in a hit. You've now managed them in a situation where you've now created increased risk for acute lung injury. That makes sense? So elderly patients are at risk for a greater degree of small airway closure than the younger person. All right, another graphic showing pretty much the same thing. We've kind of talked a bit about this at length. The small airway closure and the changes in lung compliance that occur simply as a result of putting the person in the supine position, they go together. What happens when you have airway closure? Increase or decrease your lung compliance. What is good and what is bad? Increased lung compliance will do what? You have an increase in compliance. What is compliance, folks? Somebody in Northern Virginia, what is lung compliance? In very simple terms.
The ability for the lungs to recoil back.
Okay. It's a change in what over a change in what? Change in volume over a change in pressure. So if you increase you're moving bigger volumes or you're moving at a lower pressure. So that's a good thing. Decreased compliance is what? Either not moving as much volume at the same pressure or moving the same volume at a much higher pressure. Does that make sense? It's good to kind of step back and think about that just in terms of very basic terms. What is good and what is bad? Lung volumes, compliance is dependent upon the lung volume at which your lung is sitting. This is a concept we're going to talk about here as well. At very, 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 very low lung volumes, let's say we have a lot of airway closure. How is compliance? Compliance is sucky. Yeah, at very, very low lung volumes with small airway closure, what does it mean? It takes a whole lot of pressure to get in just a little bit of volume. Then we have the sweet spot on the curve where we have a range of pretty good compliance. And then what happens at very, very, very high volumes? We're over-distending the lungs. How is compliance? Terrible. Lung compliance at very high volumes sucks. Lung compliance at very low volumes sucks. In the middle, it's nice. It's a steep curve. You see a nice change in volume with a modest increase in pressure. So lung compliance, thinking about it in those terms. I've given you these. We don't sit down in the clinical arena, perhaps unless you're with me or Dr. Billett or something of that nature, go through and calculate all of these things, but I wanted you to be familiar with that. At this point in time, I really, really, really want you to get this concept. Compliance is dependent on lung volume. It differs. In healthy lungs, compliance is relatively, not exactly the same in the upper lung units as it is in the lower, ear supine, the upper and the lower, but it's reasonably homogeneous, yes? Throughout the lung, because most of the lung units get about the same amount, not about the same exactly, but again, the gravity dependent and so forth, but, it's relatively homogeneous. As you get into a lot of these lung disorders, particularly segmental disorders and so forth, what do we know? Very heterogeneous. Not all of the lung units are created equal. We have to come up with some creative ventilatory strategies because not all of the alveoli in the lungs, from lung to lung or from region of the lung to region of the lung, are exactly the same. So the compliance is typically relatively homogeneous. But then as we get into things like significant atelectasis, when you're doing a Trendelenburg case and you've got all of the belly shoving up on the diaphragm and the diaphragm is shifted all the way up, we have extremely poor compliance in the lower half of the lungs because we've shoved all of that stuff in there. So it becomes based on the surgery, the positioning. Here's where we're starting to see this, guys. What does surgery and positioning do?